Hi everyone who took the neurobiology course by Peg Mason and everyone who are interested in a little bit about stroke. Here we watch a little compilation of moments with a patient. I attended a few weeks of his rehabilitation process as part of my graduation in physical therapy, and now I'll show you. First of all, I'd like to show the signs in his arm, but especially in his hand. He has a general weakness, be it for grasping or extending fingers, caused by an interruption of the control by the cerebral cortex. This is probably due to lesion and death of the cell bodies of neurons in the primary and sensory motor area, but can be caused by any lesion all the way through the cortical spinal tract. We see that the ability for reaching and grasping is a challenge for him. This is true because it's a volitional movement. Volitional movement is the one that needs cortical motor control centers, and this is broadly lost in this case. This patient has spasticity, which is a feature of superior motor neuron disease, and in stroke, it causes signs like hypertonia in flexor muscles, and the reason why it occurs is inflection of upper limb is still a mystery. Hyperflexion of the spinal muscles, known as the myotatic reflex, causes a lot of contraction with a few stretch of the affected group of muscles, leading to hypertonia. So these patients has an excessive withdrawal reflex, which takes place very low in the motor hierarchy. So brain is not required. And he can walk, that's great. Not so well, but he walks. His problem is mainly about weakness due to loss of cortical control of specific movements. Walking depends on the system called sternal pattern generators. This system is not affected in a focal stroke that caused hemiparesia. Sternal pattern generators (CPG) are responsible for stereotype movements like chewing, walking, standing, running, or vomiting. Then we know that CPG are working very well. Some movements of the leg are lost, but the CPG finds a way for the capacity of walking to take place. Although he cannot enough flex his hip or does flex his ankle, he makes a secundation movement with his right hip. All patients who have hemiparesia also have this great pattern. And we can know that he has posture. He needs posture for walking. He is not falling. He can overcome posture oscillations, compensating the changes in the center of mass. Sure, because the postural sway is underneath the limit for falling. Posture is another feature of CPG, sternal pattern generators. Um, I could understand that cycling is also a stereotyped movement. It's incredible he doing this. The sternal pattern generators can act very well because the muscle power involved is not too great like walking, where it's necessary weight bearing and knee and ankle movement. Cycling does require movement in these joints, but the half limb act assisting the impaired limb, so he can cycle very well. I didn't know about the prosodic content of language present in the correspondent Broca's area, in the right frontal lobe. Now, I can remember that this man was not enough expressive, and we know that he probably has a problem with this function, and probably with the correspondent Wernicke's area. Something worth noting is the fact that his left hemibarry has hemiparesia. If his left arm and leg are impaired, surely we have a problem in the right cerebral hemisphere. We learned that the right parietal lobe has a dorsal pathway about the word to the left, which are not supplemented by the left parietal lobe. Hence, he may have a deficit in the left visual field and hem neglect syndrome, but we cannot ensure this.